where are we going with second generation devices?
Well, I was the principal investigator of the Venus 2 trial, which is a fenestrated covered stent to create a percutaneous fistula. And I do think that what we've seen so far out of the results is that we have eliminated the deep venous flow problem by having a little fenestrated covered stent redirecting flow from the radial artery into the superficial veins. I think we've also, in a way, maybe structured the anastomosis. So we're not dealing with some sort of a thermal injury, fibrosis that might require, cutting balloons or angioplasty or so forth to treat subsequent stenosis. And I think we're getting smarter about making a fistula that can be easily palpated for dialysis at the dialysis center, rather than trying to train people how to do unusual cannulations at the antecubital fossa of the basilic and cephalic veins.
So let me put this to you, Kate. If all devices are available and there was no cost difference, are you going to go straight into second generation devices? Are you going to go back to using ellipsis now it's available? Are you going to start using wavelength because it's another device that creates the same sort of fistula?
Gosh, that's a really, really good question. It sounds like a great world where they're all available and you can choose. Because I think some of it, especially the differences between, say, the ellipsis and the wavelength, different anatomical territories and different mechanisms will suit different patients. So I think, there's a place absolutely 100% for both devices within, AVF care. When it comes to the difference between the ellipsis and the velocity device, I think it's about the data as well, seeing how we get there with kind of the long-term usage. And it's really interesting to hear Bart talk about, the future and maybe directing some of the flow to one vein. But then, in some patients, you get a real advantage from the split vein and the cannulation. If they've got outflow problems, for example, in the cephalic vein, we had a number of patients with central venous lesions, outflow cephalic venous lesions that benefited from that kind of multi-flow fistula.
Alex, what would you do? Are you going to go back to using ellipsis?
So
I think you've used multiple of the other devices as well.
I will say that I'm not doing brachiocephalic fistulas anymore, almost none at all, because I think they are the worst fistulas. Because they are very satisfactory when you do them, because you have a huge trill and people like them. They say, wow, look at this trill. But once they start getting developed, then the problem starts with cephalic arch stenosis, being aneurysmal fistula, skin necrosis. So I think it's not the best fistula you can do. So that's why in these patients, like 99%, I will do a Jennings fistula, like a proximal radiocephalic fistula. The Gratz type.
Gratz type fistula. And I don't know why we don't do more of those.
I think because it's not very popular in training. I discovered it when I went for my fellowship with Dr. Jennings, and I was like, why is he doing that? Because for me, before it was radiocephalic, brachiocephalic, brachiobasilic. And the thing is, when you do these fistulas, they're a bit more complicated because you go deeper. You have to get like 1 million of small veins, and the anastomosis is a bit more technical. But once you start doing them, they're wonderful.
The anatomy is nice when you get used to doing them. I think when you are taught them, I think it's important. No one gets taught these things.
Exactly.
And you discover them, and you think, why was I not doing this before?
Exactly.
Kate alluded to data. Do you think we've got enough data on these devices already, or do we need randomized trials?
Well, certainly for the velocity, the Venus 2 data has not been published yet. Venus 3 is enrolling right now. I would say to Alex, though, that something like a velocity fistula comes off the radial artery. So right away, you got a bit of a reduced flow coming in as opposed to a brachiocephalic fistula. And the second thing is that if you use this fenestrated covered stent, the aperture of it constricts some flow. So I think you may have lower flow than the typical brachiocephalic fistula. But time will tell. The data will show it.
And we're talking about second generation. If we were to invent a third generation, what would be the ideal? What would be the absolute reach for the stars here? A more distal fistula, a snuff box fistula? Is that something you think will ever be achievable?
So I think reach for the stars, which is something I'm working in my head and perhaps a bit further than in my head, is a percutaneously created graft. I think this might be a game changer for the patients that they don't have the anatomy for a straightforward, easy to use surgical fistula. So let's say a patient that you can only do a basilic vein superficialization. Is that better, or what if you can insert a percutaneously created graft, which is, you can do it in 30 minutes and then you can cannulate it and you don't need a catheter anymore. And for the trial, we are doing a trial right now. I'm taking the opportunity to let the people know so they can wait the data.
Yeah, sure.
A big shout out to the team of Bordeaux, Eric Ducasse and Caroline Caradou. We're doing together a randomized trial in France, multi-center, comparing surgery, wavelength, and ellipsis.
Okay.
And perhaps we're going to have some interesting results.
And what are the timelines on that?
We already started enrolling patients. We're already doing patients. So perhaps in the next 2-3 years, we'll have some interesting data.
Do you think the devices are comparable? Do you think the wavelength and the ellipsis are comparable devices, or are they different devices with different indications?
So the devices are different, but the outcome and the what we're aiming for is very similar, yes?
Yeah.
Because we're aiming for a fistula that will take blood through the perforator to the superficial system. Of course, the devices have technical differences. One is creating a fistula that seems to be like an iatrogenic or traumatic fistula between ulnar artery and vein or radial artery and vein, and the other theoretically creates an anastomosis between the perforator and the radial artery. But the end game, finally, it's the same. The physiology is very similar.
Yeah. What do you think about that in terms of needing trials on these things? Are we going to have to put, the velocity device up against the other two?
Well, I think having a good comparator, between percutaneous fistula and a surgically created fistula has always been a bit of a conundrum. What is the surgical fistula that you can directly compare? Maybe the Gratz type of fistula, but as we said before, not everybody's making those surgically, So trying to enroll in patients in a randomized trial like that may be a challenge. I know Alex is doing a clinical trial comparing with surgical fistulae. As far as your question about, what the role of percutaneous fistulae, what is the optimal fistula? First off, I don't think any of the percutaneous fistulae, whether it's first generation or maybe a coming second generation, replaces surgical fistulae right now. I think we still have, if somebody can get a radiocephalic fistula that works well, that's a phenomenal access, and I don't think we've marginalized the role of a surgical fistula at this point. We have to select patients with appropriate anatomy for percutaneous fistula, and that's a subset of patients who would be qualified for it. So, of course, we still need surgical fistulae to be created.
And we talk about all the good things here. What about the bad things?
Well, I think I would say the downside of percutaneous fistulae, once you create it, beside the ongoing need for surveillance and maintenance, is that, fistulae are just prone, many of them, to stenoses, thromboses, issues. And I don't think that making a percutaneous fistula takes you away from having to address problems at the cannulation site or the venous outflow. So I think that's the biggest problem we're going to see, no different than surgical fistulae.
Okay, do you see a downside?
A percutaneous fistula?
Yeah, introducing more percutaneous fistulas into what we do.
I mean, I think the question that always happens is when the patient has the transplant and you have a working percutaneous fistula, if at any point you want to shut it down, how do you shut it down with the different fistulas? There are various mechanisms you can do it, but they may involve placing a stent in a native artery to cover the anastomosis. So I think that's always been the background issue. Is there going to be any real long-term, and I'm thinking sort of 10, 15 year, any incidences of kind of higher flows over time and venous hypertension potentially?
Because of course, when you've got a transplant, this is no longer a fistula, essentially. It's an AV malformation, isn't it, in your arm? And it's how we deal with that. What do you think from a surgical point of view? You must have dealt with this issue.
I've closed a few percutaneous fistulas as I did because, I started early. So, of course, I had patients that came back and I had to close it. And basically, I closed one surgically, or I did a budding surgically. And I think it was a challenging operation because you have to, ligate multiple branches. But I closed percutaneously 3 or 4.
Yeah.
For sure 3, perhaps 4. I placed the Bentley. The first patient I tried, I placed the Bentley in the vein because I didn't want to close the artery.
Sure.
Yeah, and it didn't work. And then I placed the Bentley inside the artery.
Okay.
And basically, I placed the Bentley in front of the perforating vein, at the very origin of the radial artery, and I had to flare it a bit. But it worked beautifully. I didn't have any problems.
Yeah. So would you be unhappy putting a stent at that site?
To put a stent in the artery?
Yeah. These are often younger patients as well.
That's right. I know. I think we're reluctant to do that if the patient really needs to have a percutaneous fistula closed. it seems like that is the most effective way to treat it. Going back to something like the Velocity, you know, it's a small fenestrated cover stent, and of the 23 patients enrolled in Venos 2, one of them had to have their Velocity fenestrated stent fistula closed because they had steel. They had occlusive disease of the ulnar and radial artery, and then we made the fistula, and of course it had steel. Closing it was quite simple because...
Just to wrap things up, I'd like to put it back to you. Last year at Charing Cross, the debate was device-created fistulas are a failed experiment. Is that a fitting debate, or have we moved on from that talk now and we're now on the reascendancy? Could we say device-created fistulas are a phoenix from the ashes now?
I would probably reform the question with, have we failed our patients or percutaneously created fistulas ourselves?
And your answer?
We have, but we have a second chance.
We've got a second chance. But?
Yeah, so I'm optimistic. I think we've learned a lot from both the Wavelength and the Ellipsis. I think they're excellent devices for creating fistulae, and now we know much more about how to deal with the secondary issues about making them functional. I think a bright sign is the fact that the Ellipsis has returned and will be available. It was off the market and now has been acquired and coming back on the market. So there's still a driver there to say, yeah, we still do have people that are interested in it. And I think a second generation is promising. Again, we need more data.
So at a time when we're going back to the moon, is this, again, the space program started up again, and this is like the space program? We're back on a new program of new innovation and going to be going further forward than we were before. Do you think, Kate?
Yeah, I think so. I don't think they're a failed experiment at all. I think with every experiment, you will encounter a degree of failure and make mistakes. And that's how you make something great, as Bart has described with previous technologies.